For the second abstract will be virtual from Friday Saidi from Malawi, combination adherence support for HIV PrEP during pregnancy in Malawi, a pilot randomized trial.
Good morning. My name is Dr. Friday Saidi. I'm a research investigator at UNC Project in Malawi. I'm privileged to present results from a pilot randomized trial that we conducted here in Malawi on a combination adherence support strategy that we developed for HIV pre-exposure prophylaxis during pregnancy. As a brief background, women in sub-Saharan Africa, like Malawi, face high risk of HIV acquisition during pregnancy and postpartum, and this unfortunately attribute to high new cases of pediatric infection during this time period. And use of biomedical interventions such as PrEP in the form of amitriptyline, tenofovir, can effectively reduce HIV acquisition and is considered as an important part of global HIV prevention in pregnant and postpartum women. However, currently the uptake of PrEP among these high-risk women remains low, and therefore interventions that may support adherence to PrEP for this population remain critical. So with this background, our goal was to develop an integrated behavioral intervention that can be adapted to support PrEP adherence during pregnancy and breastfeeding. So we developed a combination adherence support strategy that was informed by our literature review, previous formative research, and as well as stakeholder engagement. We then conducted this pilot trial with the aim to obtain acceptability, fidelity, and clinical outcome data that about this combination adherence support strategy for HIV prevention. So the focus of this presentation is on the clinical outcomes data from this pilot study. So in terms of study design, this was an unmasked pilot randomized trial. Participants were randomized equally between the intervention and control arm, and they were initiated on FTC TDF as part of PrEP, which they were taking daily. And we enrolled women who were HIV negative and pregnant and aged 18 and above, and who were judged as high risk for HIV acquisition based on local guidelines. We recruited these women at one of the busiest maternity hospitals in Malawi, in the Longwe, was called Bailam, that sees an average of about 1,500 deliveries per month. Our sample size was 200 women, and we recruited them between June 2020 and November 2021. This diagram summarizes the intervention components. These are the ones that are noted above here on top: integrated next step counseling as well as the adherence support. These were the two intervention components that were given to those that were randomized to the intervention arm. And the other floor just outlines the visits that we did from enrollment to month 6. So the follow-up between the two groups was up to 6 months. So in terms of the two intervention components, INSC, which is the next step counseling, is the patient-centered counseling approach that adopts a systematic process or flow of conversation that is aimed at promoting patient engagement and autonomy. And for this, counselors, they actually guide the conversation towards the identification of needs that are related to health and well-being, sexual health protection, as well as adherence. So they sort of, the participants were sort of empowered to identify barriers that, and as well as solutions that may work in their circumstances to improve adherence to PrEP. This INSC has initially been used to support PrEP in high-risk population that include men that have sex with men, but has not yet been used in the population that we have used in breastfeeding, pregnant breastfeeding women. On top of this intervention of INSC, we also had an option of a participant being encouraged to select an adherence supporter who may be either a partner or a close relative that can support them in terms of adherence. And this part of the intervention was actually optional. And then in terms of the follow-up visits, as I noted, they were up to 6 months, and within those 6 months, we also collected clinical data of interest, of note. We took samples, blood samples at month 3 and 6 to measure turnover concentration. This was mainly to confirm whether the participants were adhering to PrEP. In terms of study arms, we had the control arm where participants were initially on PrEP, and they were also getting the regular HIV testing and testing and counseling, and as well as adherence counseling. And for the intervention, it was also similar. They were initially on oral PrEP screening, and they also had received adherence counseling and regular HIV testing. And then on top of that, they were given this patient-centered counseling and the adherence supporter component as part of the intervention. In terms of our clinical trial, clinical outcomes, we examined retention in care for 3 and 6 months, and we also examined retention in care with functional adherence to PrEP as measured by plasma and intracellular turnover drug concentration at 3 and 6 months following study enrollment. Using an algorithm that has been published by Cornell and friends, results from the plasma and upper cell layers of pegged cells assays were combined to develop a composite adherence score based on functional adherence. So this table just summarizes the categories that were used to assess the functional adherence from level 0, which highlights no doses in the interval that the participant was seen, to level 4, which estimated a dose of at least 4 to 5 doses per week, and then level 5, which highlighted an approximation of daily dosing. So in terms of the results, instead of results, we screened 255 HIV negative women, and of those, 53 were not eligible with the reasons highlighted here, and we enrolled 200 as our planned sample size, and these were randomized equally, 100 in intervention and 100 in control. 83 of those that were in the intervention completed their three study visits, that baseline and month 1, month 3, and month 6, and then for those that were in the control arm, 79 completed their visits. And based on our primary outcome of retention in care with functional adherence, we included all the women in the primary analysis. So this table summarizes the demographic characteristics of our women. They were actually generally similar with some chance imbalances that we noted on those that are highlighted in yellow. Looking at the results of our adherence scores, I think this diagram summarizes the adherence scores at 3 and 6 months for our participants based on the Cornell algorithm. The colors here show these results according to the levels that I previously described, with the white color being level 0, green being level 4, and dark green level 5. As you may see here, less than a third of our participants had turnover algorithm scores consistent with functional adherence at either time point. That's at month 3, and month 6. And this was similar in both the control and intervention. So looking at the composite outcome of retention and functional adherence, no differences were noted between the intervention and control groups at 3 months. So this, you see that there's around 28% in the intervention versus 29% in the control, with a risk difference of -0.7%. And at 6 months, it was 22% the intervention versus 26% in the control, with a risk difference of -3. So in short, for those that were retained in care, they also had low levels of tenofovir noted at the time of follow-up. To conclude, we enrolled and we successfully enrolled and randomized and retained the pregnant women in this pilot trial. But however, we noted that there was low levels of tenofovir concentration during the time we were following up. So pharmacologically confirmed PrEP adherence was low, and this was in a setting of a clinical trial, and this is quite an important finding that should be considered in any future studies. I would like to thank our study teams and the PIs, Professor Benchi and Professor Mtali, as well as the participants who were involved in this trial and the funders for this trial. Thank you.